Hello everybody, my name is Hayden Wishart and today I'm going to be talking to you about the female athlete triad. In recent times, the number of women who are participating in organised sports has grown dramatically. While this involvement in sports has led to many significant health benefits for women, there are several medical disorders that have become associated with the increased number of female athletes. The potential medical disorders accompanying the female athlete triad is a serious syndrome comprising of three interrelated components. These components include disordered eating, amenorrhea, and osteoporosis. In 2007, the American College of Sports Medicine updated the previous statement regarding the female athlete triad. The new ideology of the female athlete triad places emphasis on having a decreased energy availability rather than just the diagnosis of having disordered eating, which in turn leads to menstrual irregularities and negative effects on overall bone health. Anorexia nervosa and bulimia nervosa are both complex disorders that involve the unusual obsession with weight and body shape. Whilst this links the two syndromes, there are distinctive patterns of weight regulation and eating behaviour that clinically differentiates between the two conditions. With anorexia nervosa, there is an enduring purposeful restriction of food intake with the goal to achieve profound skinniness in the attempt to feel self-worth. In bulimia nervosa, average body weight is maintained throughout the illness, while advanced dieting and further weight loss is most likely desired. Those suffering from bulimia nervosa often experience recurring disinhibition of restraint, which results in cycles of binge eating followed by compensatory actions to remove the food, such as self-induced vomiting, abuse of laxatives and diuretics, extreme exercise, and restricting diet. It is also important to establish clinical disordered eaters are often accompanied by comorbid psychological conditions such as depression, anxiety disorder, and obsessive compulsive disorder. The spectrum of low energy availability ranges from inadequate intake without the associated abnormal eating behaviors such as bulimia and anorexia nervosa. Some athletes may have low energy availability due to purposeful calorie restriction or increased energy expenditure due to their athletic demands, whereas others may fall into this category as they are simply unaware of their true caloric needs. When energy availability falls below the required threshold, normal physiological maintenance, growth, and reproductive mechanisms become disordered. Females who participate in sports that have an emphasis on low weight are at the greatest risk for developing one or more of the components of the triad, including disordered eating. These sports include dance and gymnastics, as performance is subjectively scored, distance running and cross-country skiing, as they are endurance events that favour low body weight, volleyball and swimming, as athletes wear revealing clothing, and martial arts and boxing, which are sports which have weight categories. Primary amenorrhea is defined as failure to menstruate by the age of 15. Secondary amenorrhea is defined as absence of menses for more than 3 months after a monthly cycle has previously been set. Within the range is also oligomenorrhea, which encompasses having fewer than 9 cycles per year. The clinical diagnosis for menstrual disorders of oligomenorrhea are menstrual cycles greater than 35 days apart. The type of amenorrhea, which is caused by low energy availability, is called functional hypothalamic amenorrhea, which is where ovarian function is suppressed by an abnormally slow frequency of luteinizing hormone pulses in the blood. Female athletes with menstrual irregularities are primary concern as they are directly related to bone mineral density. In the general population, the prevalence of primary amenorrhea is less than 1% and up to 4% for secondary amenorrhea. Whereas for high school athletic population, the estimates ranging from 20% to 54%, and the collegiate athletic population ranging from 26% to 69%. The prevalence of amenorrhea varies widely depending on sport, age, training volume, and body weight. Among collegiate runners, the prevalence is found to increase from 3% to 65% as training mileage increased from less than 13 kilometers per week to greater than 113 kilometers per week, while body weight decreased from more than 60% to less, from more than 60 kilos to less than 50 kilos. Osteoporosis refers to inadequate bone formation and premature bone loss, which results in low bone mass and the coinciding increased risk of suffering a bone fracture. Studies have shown that women with amenorrhea have been found to have lower vertebral bone mineral densities compared to healthy women. It was reported that the vertebral bone mineral density was significantly lower in athletes who had a history of lifetime regular menses, and the linear relationship occurred between these irregularities and the lower levels of bone mineral density in the vertebrae. Female athletes with amenorrhea can lead to estrogen deficiencies, which contributes to an increase in osteoclast activity, which can further contribute to the low bone mass experienced in amenorrheic athletes. Inadequate bone formation and premature bone loss can lead to the failure to achieve peak bone mass during adolescence and young adulthood, which often leads to osteoporosis and increased fracture risk later in life. To help prevent female athletes being affected by the components of the triad, a multidisciplinary team is key to being successful. Health professionals involved should consist of healthcare providers, mental health practitioners, dietitians, coaches, parents, athletic trainers, exercise physiologists, and physical therapists. The goal should be to educate athletes about energy availability, nutritional intake, and having the right balance between intake with energy output to avoid the condition. Non-pharmacological treatment is the first step recommended for female athletes to combat the triad to increase energy availability by either increasing dietary intake or decreasing energy expenditure. Nutritional counselling is needed to achieve the restoring of adequate energy availability, which would also include recommendations on daily intake of calcium and vitamin D. Training changes should also be recommended by changing the routine of mainly cardiovascular endurance training to more of a focus on resistance and weight training. It may be necessary for estrogen therapy through oral contraceptive pills in adolescent athlete females who are either in primary amenorrhea at the age of 15 or in secondary amenorrhea occurring 3 years post-menarche. Calcium and vitamin D supplementation is often prescribed for amenorrheic athletes who are low in these essential vitamins and minerals. However, there is no consensus on necessary dosage.